Hello, I'm Dr. James Gammie from Johns Hopkins, and it's my privilege to be presenting at the upcoming American Heart Association meeting the results of an important trial that addresses a key surgical question in the treatment of heart valve disease. This was a trial, and by way of background, is focused on valvular heart disease, and in particular, patients with mitral regurgitation. Mitral regurgitation is leakage of the mitral valve, and it is the most common valvular disorder in the United States and around the world. There's more than 50,000 operations that are done every year in the United States for mitral regurgitation. And also by way of background, there's another valve on the opposite side of the heart called the tricuspid valve. And the tricuspid valve is often impacted by a leaky mitral valve. So a lot of our patients that come for mitral valve surgery have leakage of the tricuspid valve because the blood backs up across the pulmonary circulation and it stretches the borders of the tricuspid valve. It dilates and it causes tricuspid regurgitation or tricuspid leakage. And so commonly we're faced with the dilemma about whether or not to do concomitant surgery on the tricuspid valve at the time that we're either fixing or replacing the mitral valve. And we grade the amount of leakage of the tricuspid valve as mild, moderate, or severe. I think there's general agreement amongst surgeons that if there's severe leakage of the tricuspid valve, that we should fix it. And we have a good way of fixing it by placing a rigid cloth-covered metal ring, an annuloplasty, it's called, around the periphery of the valve. And that narrows down the opening of the valve and it takes away the leakage. And I think there's little controversy about what to do with severe tricuspid regurgitation. However, we're not sure how to manage moderate or even less than moderate leakage, particularly when there's dilation of the tricuspid valve. And there's a lot of, or there has been a lot of controversy within our field and great variability in practice. For example, overall, presently, about a third of patients with a moderate tricuspid leakage will get repair at the time of mitral valve surgery. And different centers approach this differently, and the rates of concomitant repair are as low as 5% in some centers and as high as 75% in other centers. The reason that we want to fix the valve at the time of surgery is to prevent progression of the leakage. We know that sometimes the leakage of the tricuspid valve goes down when we fix the mitral valve, but it's not reliable. And it has been demonstrated that some patients will have progressive leakage of the tricuspid valve. And that can cause shortness of breath, it can cause fluid accumulation, and importantly, it's been shown to be an independent predictor of long-term mortality. So that sets the stage for this trial, and it was carried out at 39 centers, including in the United States, Canada, and in Germany. And it was also in part supported by the German Heart Foundation. And we took patients that had the most common form of a leaky mitral valve. It's called degenerative mitral regurgitation. And they either had a moderate leak of the tricuspid valve, or they had less than moderate and a stretched or dilated tricuspid valve. And we took 401 patients and we randomly assigned them to either get mitral valve surgery alone or mitral valve surgery with tricuspid valve repair. And one of the shortcomings of surgical trials is that sometimes surgeons do things a lot of different ways. One of the powerful aspects of this trial was that we got agreement amongst the surgeons to use the specific type of device, the specific size of device. It tended to be small, what we call undersized, and rigid and non-planar. So that was the setting. We screened over 5,000 patients, 800 and some were eligible for the trial, and 401 agreed to participate. And we carried this out between 2016 and 2018. And the primary endpoint of the trial was assessed 2 years after surgery. And it was a composite endpoint of either death, reoperation for tricuspid regurgitation, or progression of tricuspid regurgitation to severe tricuspid regurgitation. We also looked at a host of secondary endpoints, including quality of life, major adverse events, the performance, function, and size of the right ventricle, and whether the patient was admitted for heart failure, and overall how well they did. And so the key findings of the trial, first of all, was that the operative mortality amongst these 401 patients was extraordinarily low. It was less than 1%. And I think this speaks to the effectiveness and safety of isolated mitral valve surgery. And then the key finding was that treatment failure, as defined by our composite endpoint of death, reoperation for tricuspid regurgitation, or severe TR, was more frequent in the group that did not have the tricuspid valve fixed. And the numbers were that 10.2% of patients achieved the primary endpoint in the mitral valve surgery alone, whereas we only saw that in 3.9% of those patients where we fixed the tricuspid valve at the time of surgery. The 2-year mortality was really not particularly different. And really the main driver of the primary endpoint was progression of severe tricuspid regurgitation, which we saw in 5.6% of patients that were not treated. And we saw that in only 0.6%, one patient out of 179 patients where we put the annuloplasty ring in place had progressed to severe tricuspid regurgitation. We found that the repair of tricuspid insufficiency or regurgitation did come at a cost. Those patients were on the heart-lung machine for approximately 34 minutes longer in the operating room. They also had a median length of stay in the hospital, at least in Canada and the United States, of 2 days. So it took longer on the bypass machine, and they had a longer postoperative length of stay. And then very importantly, we know as surgeons that repairing the tricuspid valve with an annuloplasty ring sometimes increases or does increase. It's well known that it increases the risk of a patient needing a permanent pacemaker after the operation. And we did find a significant difference in the need for a permanent pacemaker. The pacemaker implantation rate was 14% in the group where we fixed the tricuspid valve, but it was only 2.5% in the group where we did not have to fix the tricuspid valve. And then finally, or two other points I would make, is that the presence of either moderate or severe tricuspid regurgitation in comparing the two groups was substantially higher in the group where we did not fix the tricuspid valve. It was 25%, a quarter of patients had progressed to either moderate or severe tricuspid regurgitation in that group, whereas we only saw that in 3.5% of those patients where the tricuspid valve was fixed. So this is an important trial because it is the first time that we have high-level evidence to help us understand what to do in the operating room. I'm not sure that we have absolute clear guidelines here, but I think that we now know that progression of TR is very effectively arrested with a use of tricuspid valve repair with a ring. But we also know that it comes at a cost of increased pacemaker implantation. Importantly, our patient population is a young patient population, typically in their 60s, and these patients generally have a normal life expectancy after mitral valve surgery, mitral or tricuspid valve surgery. And so this trial has been designed to continue to follow the patients out to 5 years, and it will be very important for us to do that. And we look forward to reporting the results of the 5-year assessment and whether there's further progression of tricuspid regurgitation in the untreated group and whether or not that has an impact on their clinical outcomes.